I'm here today to discuss frozen shoulder with you, a very common shoulder complaint. Some of you may, however, know this as adhesive capsulitis. And in 2014, Jeremy Lewis coined the term frozen shoulder contracture syndrome. So some of you may know frozen shoulder as that. Frozen shoulder occurs due to inflammation, and eventually this leads to a contracture of the glenohumeral joint ligaments, the coracohumeral ligament, and the joint capsule itself. There are several causes of frozen shoulder. There is a higher prevalence among women and those who suffer with diabetes or thyroid issues. There is also a higher prevalence of frozen shoulder among those who have had their arm immobilised for a sustained period of time, such as following a fracture where they've had to have their arm immobilised in a collar and cuff for a while, or following surgery. What are the symptoms of frozen shoulder? Well, the first movement to go is always active and passive lateral rotation or external rotation of the glenohumeral joint. So that movement, an outward rotation, that is always the first to go, followed by elevation of the shoulder. So this can be in abduction or it can be in flexion in the frontal plane. Reeves in 1975 found that frozen shoulder took place in 3 stages. The first, frozen, which is elicited by a great deal of pain. The second stage is known as freezing, or the patient may describe not so much pain but more stiffness occurring in the shoulder. A limited movement. So as mentioned, limited into external rotation, both actively, so the patient doing it themselves, and passively, performed by the therapist. The third stage is known as thawing, which is the recovery phase. Other symptoms may include an inability to sleep on the affected side. The length of time for frozen shoulder to resolve is said to be 30.1 months, which equates to an average of between 2 and 4 years. So as you can see, the patient can experience pain and or stiffness for a significant period of time. Unfortunately though, there is no gold standard to assess for frozen shoulder. Instead, it is based on a sound clinical examination and a physical examination and the possibility of an X-ray being performed. It must be noted that an X-ray for frozen shoulder should come back as normal. In other words, no bony abnormalities will be seen on the X-ray. If there are, then frozen shoulder is highly likely to be the issue, and instead it may be something like osteoarthritis, a fracture, or other bony issues which can contribute to shoulder stiffness. Unfortunately, there is no one specific cure for frozen shoulder. Instead, it is about providing symptom relief and reducing the disabilities for the patient. There is a poor response for the use of analgesia and NSAIDs or anti-inflammatories. However, if the patient may be experiencing ongoing symptoms for between 2 and 4 years, then they may well want to take some of these medications available to them. There is poor evidence for long-term use, but strong evidence for short-term and medium-term use of a ultrasound-guided corticosteroid injection. However, these should be performed no more than 3 times a year and only 1 in a month. There is some strong evidence for the use of physiotherapy. So adjuncts can include myofascial release, passive movements being conducted, and exercise in the session or a home exercise program being provided. Acupuncture, however, is equivocal. Hydrodilatation or hydrodistension or other surgical approaches, which can include MUA, so immobilization under anaesthetic, and an arthroscopic capture release, can be performed, which are more invasive, obviously, and then physiotherapy should be conducted intensely after those procedures have taken place. Thank you for watching. Don't forget you can subscribe to On The Go Physio above. The link is there for more videos. Thanks for watching.